right, good afternoon, everyone. Again, this is Sean Kennedy from the Massachusetts eHealth Institute, and welcome to our webinar entitled MeHI Consent Operationalizing Opt-in. Today we've got a great panel of speakers to share with you what's going on in the HIway about the consent and operationalizing opt-in. Before we do that, though, allow me to briefly share with you a little bit about Massachusetts eHealth Institute for those of you that may not be familiar with us. We're actually a child institute under the Mass Technology Collaborative, which is a division of the Massachusetts, MeHI is a division of Mass Tech, which is a public economic development agency, and there's three sister institutes that sits under there, the Innovation Institute, the Massachusetts Broadband Institute, and then MeHI, the Massachusetts eHealth Institute. And our job is to help with all things health IT, coordinating healthcare innovation, technology and competitiveness, accelerating the adoption of health information technologies, promoting health IT to improve safety, quality, and efficiency in healthcare, advancing the dissemination of electronic health records. Essentially, we like to think that we're here to help with all things that are e-health or health IT related. I want to thank each of you for joining this afternoon. It's really wonderful to have such great participation. We think this is a fantastic topic that we'll be getting into, and we've got some good speakers. So what we'd like you to be able to walk away with today from a learning objective standpoint is we'd like you to be able to describe the Massachusetts HIE opt-in legislative mandate, should be able to locate and share community-developed MeHI consent resources, should be able to describe the different approaches organizations are taking to meet the opt-in mandate, and be able to recognize the various technical, policy, procedural elements to consent. To get there, we'll work through the following agenda, where we'll start out with Amy Karen from HIway Operations offering an overview of the HIway opt-in legislative mandate, and then reviewing the community-developed MeHI consent resources. And then we've got two guest speakers, Christine Griffin from Partners Healthcare, Mass General, and then John Halamka from Beth Israel Deaconess Medical Center, and they'll share their approaches to meeting this opt-in mandate. So with that, we're going to go ahead and introduce here. We've got the following speakers that are going to be part of this broadcast. You've heard enough from me now. We're going to turn it over here to Amy Karen, who's the project manager for MeHI Communications, Outreach, and Education as part of the Executive Office of Health and Human Services. You'll then hear from Christine Griffin, who is the Health Information Services Manager over at Mass General in the Health Information Services area. And then we'll end up hearing with John Halamka, who's the CIO at Beth Israel Deaconess Medical Center. So with that, I'm going to turn the controls over to Amy Karen, and I'm going to invite Amy to share more on what EOHHS and MeHI are doing and helping us all through this operationalizing opt-in. Go ahead, Amy.
Thanks, Sean, and thanks as always to MeHI and the team over there for helping us to host these educational sessions for the community. So just a quick refresher on the MeHI. It's a secure statewide health information exchange network. We are operated by the Executive Office of Health and Human Services. We're licensed, open to all Mass licensed providers for information sharing is allowed under HIPAA. We're governed by an HIT council. We have several advisory groups that provide input regularly. I just want to touch upon a couple of another organization that we're working with because I know this is sort of a point of confusion. So the Massachusetts eHealth Institute ran our Last Mile program for us, which ended back in February. The goal was to increase adoption and utilization of the MeHI, and that program has ended, but thankfully we have been able to secure the team to continue the efforts, and that team is with the Massachusetts eHealth Collaborative. And so this is really it's a good point to say this because the hope is we'll be setting up more of a user support network, and the team over at MeHI will be following up with webinar attendees as needed. And as these educational sessions go along, that's sort of going to be the new way that we'll all be working together. But again, we all work together on this, and we are all closely connected. So whether you're talking to any of us from any of the organizations, we'll be able to provide you the information that you need. The important point to remember when we talk about consent for the MeHI is that unlike other HIE models, we're not a hub-and-spoke model HIE. That means we don't have a data repository of health information. Instead, we provide a secure communications channel for authorized users to send and receive health information and to connect with one another. The goals of HIE are to serve as a tool to improve healthcare quality and patient outcomes, all while controlling costs. The core services that we offer are direct messaging, which enables a secure push of information. It essentially replaces the fax machine or the USB or an insecure email. Query and Retrieve enables a search and retrieval of health information, and we'll go into that a little bit more later on. So the legislation that covers consent for MeHI is Chapter 118I, Section 11, and it states that patients must opt in to the health information exchange and have that option to opt out at any time before we can use it. So, and we need to establish a mechanism in which to do that. So that's what organizations sign to when they sign our participation agreement. There are policies that outline the information around consent, and that we'll get into in a little bit later as well. So the process for opt-in is very different than opt-out, which that model basically automatically signs up a patient for the health information exchange until that patient takes required action to opt out, which is maybe it's signing a form or whatever it is that HIE requires. So the opt-in model has been tested here in Massachusetts and elsewhere, and it's really considered the preferred model in a lot of cases because it builds that patient trust and buy-in, which helps to keep the opt-in rates up. And the patient-centric approach can help boost patient engagement overall, which I think we all know can have a positive impact on patient care and health outcomes as a whole. Here are the relevant consent policies that each participant signs to. So you need to get consent to use the MeHI for that patient care, and that consent pertains solely to the use of the MeHI. That means you still need to get any and all additional patient consents required by law to share any sensitive information. Transactions that are not subject to the patient consent policy, and I will say that this is new. I don't think it's actually not in the current version of our policies and procedure document, but that's going to be released early October. So these are new. Those covered under a separate statutory authority, and this includes mandatory public health reporting, are not subject to this consent policy, nor are HIPAA-defined administrative transactions that directly support payment or anything that's sent over the MeHI between a covered entity and its business associate for the purpose of healthcare operations. Participants must have a process to allow patients to change their consent preference and to notify the MeHI. There's no duration around MeHI consent. So you can follow your existing policies when it comes to emancipated or mature minors, but to support this, and this is a new feature for Query and Retrieve especially, the MeHI will automatically reset a patient's consent status on their 18th birthday, and we'll go into a little bit more on Query and Retrieve and how it works in a little bit. So a big issue that we ran up against as we were drafting these policies and reviewing them with the community was consent for MeHI and changes in functionality. So in the current state, that would be, say, if you've implemented or adopted direct messaging, then you want to add Query and Retrieve, because really technically what the statute says is you need to get consent for the MeHI, so that would include direct messaging. Now, for direct messaging, consent conceptually is relatively easy. You need to get permission from patients that the MeHI can be used as a mode of exchange. But given that the nature of Query and Retrieve services are different, consent needs to be more robust. So the concern was that existing participants would need to reconsent their patients as they implemented Query and Retrieve, which a couple of our early adopters have already gone through and had to reconcile. So in the policies for go forward, we note that a participant can get a general consent for the MeHI at one time, regardless of whether or not they're implementing all of the services, including query and retrieve. So that would mean that the patient gets the understanding as to what the services are as a whole, including query and retrieve, whether or not you're going to implement it. So you could do that consent once, adopt direct messaging, and then you'll have that consent ready or your process ready to just move into a query and retrieve implementation down the road. I'll also say that when we talk about that, we thought about what new services might be coming down the pike for the MeHIway, and at this time we don't anticipate that any additional functionality is really going to require any additional consent from patients. But in the new policies and procedures, you'll see that the MeHIway does reserve the right to require additional consent if appropriate to new functionality. But again, when we looked at the roadmap, we didn't really see anything coming that would require it. Why is consent different for query and retrieve? Well, the pull model is different, and here's a sort of quick and dirty overview as to how it works. So an admit, transfer, discharge ADT notification is sent to the MeHIway with a consent flag of yes or no. If it's a no, we dump it at the door, and if it's a yes, this is demographic information only will be captured and stored in this Enterprise Master Patient Index, or the EMPI. So from there, the patient's relationship to that organization is made viewable by search in this relationship listing service. So at that point, other participants that can locate where medical records on their patient might be located, and then make a medical request for information, either using the HIway or whatever means that they choose. Now, this is all enabled by patient consent. So again, it's not a pull model from a data repository, but what it does is with that patient's consent, their relationship to that organization is made viewable, and then you as a querying party can say, oh, okay, I'll reach out to X organization for a medical record request. So you're not pulling data from any repository. And the data that we collect, again, it's all demographic, so it's first and last name, gender, email, address, and the medical record number from the institution. We don't collect Social Security number, and that information is not stored. So basically, for consent, a patient needs to know that the healthcare organization that's using the MeHIway is going to be sending that demographic data about them to the MeHIway, which is the state. That demographic data will need to be stored by the MeHIway, and it's going to be searchable by other authorized users. The patient's relationship to that healthcare organization, meaning that the patient has received care there, is going to be published and made viewable or disclosed to other authorized users. And that organization will be enabled to use the MeHIway to make a medical record request to those other authorized users involved in that patient's care. And we also want to know want the patients to know as a part of consent that, of course, the data is secure in transport. The MeHIway doesn't receive or store any health data. They can change their mind at any time. They have a right to receive a log of who's made requests for information, and that's something that the MeHIway can provide to our participants. And really the big sort of high-level soundbite is that, again, all of this is meant to replace insecure methods of sending and receiving information, and to help the healthcare team stay better coordinated by knowing where that patient has gone for care in the past. What's missing from all of this is that the MeHIway doesn't tell you as participants how to implement consent. The only thing that is stated is that your process needs to be auditable, and consent must be documented, among the other policies. So some participants have asked for, just tell me the process or what's the audit criteria, but we wanted to allow for flexibility because there are just multiple different organizations types out there that we want to make sure can use the MeHIway. So we want to enable them that flexibility to implement a process that's really going to work for them and for their patients. So when we say that a process should be auditable, and I say this kind of lightly but not really, I mean, we think about more so being accountable to the patient and, being accountable to your policies and procedures and your privacy practices and less to this, audit of some other organization coming in, right? Because you really want to make sure that your organization is protected, and your best bet in doing so is making sure that the patient is really informed of what they're signing for. So it's like, we don't want anybody going to any consumer protection agency and saying, well, I, didn't realize what I was signing for, and, that's not going to come from us. That's really going to come from how this is presented to your patients and the level of comfortability they have when they sign their consent form. So instead of requiring the specific process or any standardized forms, the MeHI convened some key participants, early adopters. BIDMIC, Beth Israel Deaconess, and partners who you hear from today were included. We went through this for months with our advisory groups. That's providers, legal and policy, consumers, of course. They were really involved in this. And, of course, the HIT Council reviewed all of this to, the goals were to look at the legislation, look at our policies, and then create a sort of a sample, workable process that we all felt, they all felt as healthcare organizations would be workable for any organization to adapt to, and that it's a patient-centric process. So here's where the community landed. The thought was to use really simple consent language. The purpose of that is so it can be easily adapted into existing consent forms, or can be used as a standalone form. But along with that simple consent language, you want to give the patient easy to understand educational material that covers the main points of what they need to know about what the MeHI is. You want to give them the time to review it before making their choice, and that may mean for some that they end up taking it home and then providing their consent to you at another time. Operationally, I know that gets tricky, and again, you'll hear from participants on that. But again, the goal of that is to make sure that we allow the patient to be informed as to what they're signing for, so you can just sort of move on from it and then begin to use the MeHI. Another big point in this is that the folks on the front lines that are going to be managing consent, they need to understand what the MeHI is as well. So we created a flexible PowerPoint that includes all of the specifics that they need to know, and certainly allows for you to add in any additional information as to the privacy and security practices at your institution, because again, the records stay with you as the participants, not by the HIway. So that's ultimately something that's going to come up. But you really need to try and make sure that your front-end staff is ready to have a conversation with patients as they are given the forms before they sign. Again, all these materials are meant to be flexible, and you're able to build upon them or adapt them to your population. There's the link for all of the forms there. And I think we have so here's the sample simple consent language that we landed on. So again, I consent to allow my provider to use the MeHI to disclose my medical information to other authorized healthcare organizations, right? And this is given in addition to the educational material. So here's this is the MeHI provided PDF document that is also available on the website. We also have a free text Word document with all of the same information, so it can be adapted to your existing patient educational material or repurposed and branded by your organization. It really depends on how you look at it. On the one hand, it would be great if a patient saw the same form at every healthcare organization. So no matter where they go, they would recognize it and say, oh, it's the MeHI. I know what that is. I'll sign it. That's great. But on the other hand, a patient may look at it and not recognize this service as being a part of what your organization provides. Their trusted healthcare organization, and may see it as a state-run program that they may not want to participate in. So if you think that that might be the case, then adapting this material into a format that your patients are comfortable with and are used to seeing may be the best. Again, this is your choice. So you'll hear more on best practices and things to consider when implementing consent from Christine and Dr. Halamka, because it's certainly better coming from them than from me. But here are a couple of the things that we've heard so far. Changing your consent forms and educating your staff can take time, so you want to start early and engage all teams. And you may want to also have regularly scheduled check-ins with the team after implementing the process to review your opt-in rates and address any gaps if needed. You want to address any particular patient needs in your population, such as translation for educational material. It's not something that the state is going to provide just yet, but again, we'll see how this goes down the road. And patient participation really drives your use of the MeHI, so without their buy-in, you're not going to see that long-term return on investment in your implementation. So if you're implementing query and retrieve, engage your vendor early if you need to, because your system needs to be able to generate HL7s with that yes consent flag to populate the RLS, and that may take some customization. You also may need to customize your registration screen to make sure that staff knows who's been consented and who hasn't. And if you're getting consent for direct messaging only, it's okay. Just remember, we would need to get a new consent, using the educational material to make sure your patients are aware if you do decide to implement query and retrieve. And your staff need to be able to discuss the MeHI with your patients, and your staff needs to have an internal escalation path if they have questions. There's actually a number on the educational material that directs patients to the MeHI, which is AKA me, which is fine, and we expect that there will be a few people from time to time that want to speak to us directly. And I will keep participants updated as those calls come in and see how we need to adjust our material or see what patients are saying. But again, the frontline staff should have an internal contact to go to first for anything that may come up, especially because many patients will be, again, prompted to ask about how data is stored by your institution and why it's being shared and things like that. On the couple of calls that I have had, it's been interesting that once I explain that the state doesn't collect or store their health data, and we're essentially just trying to really move away from insecure methods of information sharing, like a fax or email. There's been a general sort of aha kind of moment, and there's been some just like a genuine excitement that this is the direction that we're moving in. So that's really a main point that we want to drive home as we're discussing this with patients. So with that, I think, Sean, I will pass it back over to you to introduce Christine.
That's great. Thanks a lot, Amy. That was wonderful information. So our next speaker is Christine Griffin. She's a manager at Health Information Services at Massachusetts General Hospital. She serves as MGH's dedicated HIway consent implementation project manager. Christine also serves as HIPAA privacy and security subject matter expert. From 0709, Christine served as Mass General's privacy manager overseeing HIPAA compliance and is a licensed attorney in Massachusetts. Christine, with that, I will give the controls to you and allow you to take over.
Okay, thank you, Sean, and thanks, Amy. So as I prepared to discuss our experience with implementing a HIway consent process today, what I found most striking is how quickly we were able to implement the consent process despite the many complexities that we grappled with during the process. So I hope you'll find today's talk both encouraging and also hope that by sharing it will help others out there to navigate their own course. So I'm going to start out by giving you some history on how we got to where we are today with the consent process at MGH, what we're currently doing, and where we hope to be in the near future. So first off, earlier this year, the Director of Health Information and Privacy at Mass General, who also happens to sit on the Mass HIT Council, was asked to shepherd this HIway consent project for partners. And what she did first was get together a work group called the HIway Consent Implementation Work Group. She pulled together the right team of people, and they were able to get most of this work done. And one of the major drivers for putting this consent in place, of course, was for us meaningful use. So we shaped our consent process and our strategy around what we needed to do to meet meaningful use. Meaningful use also set a very firm timeline for us. We knew we needed a HIway opt-in process in place by October 1st, and we wanted to be able to hit the ground running with sending these clinical transition of care summaries over the HIway for as many patient discharges as possible come October. So with these meaningful use goals in mind, we knew we really had to take an organizational approach to both maximize our opportunities to obtain patient consent and also to pool all the opt-ins. So patients would only have to be asked one time rather than at every appointment, at every office, and every institution within partners. We also knew we had to create a process that would sync with the fact that Partners is deploying a single system-wide integrated electronic medical record and administrative system over the next several years. So with all of that in mind, we knew we needed to collect consent one time, store it electronically so we'd be able to send the transactions to the HIway, and also be able to consistently apply it throughout Partners. So believe it or not, we looked at some of our existing processes and we started to strategize, and this is what we found. We had a HIPAA notice, privacy notice and patient acknowledgement form with a flag and all the local registration systems, and that was also something that flowed up to our Partners EMPI and was stored at the organization's EMPI level. That was something that we hand to patient and we get them to sign off on one time, and that applies going forward. We also have a patient portal, and that's a great way to efficiently share information with patients. But we also knew that not everyone is using the portal, and we didn't want to miss certain populations. And then we have our general release of information form. It's an authorization to release protected health information. This is a paper form. We do have it on our website, but it is really just a paper form. It needs to be faxed. It needs to be scanned, so that wasn't very helpful. We didn't have one Partner's consistent consent to treat form. Sites had their own unique forms, and some didn't have a form that they were using, so that wasn't very helpful. But the privacy notice was the most helpful, and what we did was that the decision was made to build our consent process workflow mirroring the privacy notice and acknowledgement form. So through this consent implementation work group that was started meeting weekly beginning in February and is continuing to still meet at this time, a consent form was created, vetted, and approved, and also our patient handouts educational material. So the strategy that we came up with was that we would build a this HIway consent form that we approved into the Partners eCare registration system that would eventually be used throughout all of Partners. Currently, it's just being used at Newton Wellesley and as of July at Mass General. Through the use of our eCare registration system in this electronic form, we synced it up with the registration's current workflow so that the HIway consent form is listed in a documents table in the system with the other forms that the patient has to sign when they come in. The other forms are the HIPAA privacy notice acknowledgement, a consent to treat, and there may be others as well. So you'll see the HIway consent right in that list. And front desk staff were trained to look at that list to see if that form's already been received, and if it has not been received, if it's blank or unable to obtain located there in that status, then they would introduce the HIway to the patient, give the patient educational handouts, and ask them to sign. We are also very lucky that we're using not just an e-form, but signature pads. So the patient signs on a signature pad, and this directly updates the status in the registration system to received. So as of July, MGH went live with this new registration system and at the same time, we went live with the HIway consent form. Sites not on eCare at this time are either building flags within their local registration systems or using existing flags that were in their local registration systems. And the different flags are all feeding up to the partner's EMPI, so that the EMPI is the source of truth and goes back down and populates future encounter visits. So if the patient opts in over at Mass General and Epic, Brigham can then see in their local system, oh, this patient has already consented, I don't need to ask them again, and vice versa. So that was a way that we could really maximize our consent opt-ins. Okay, so going forward, now that we have it at the check-in areas, we also want to start collecting consent in our patient portal as well. This is just in the proposed stage, it's in development, but we are not there yet. In addition to collecting consent in our patient portal, we would like, and we are working on, putting a flag also in our electronic health record. And that flag would be for two purposes. One would be that a physician would be able to see if the patient's consented and opted into the HIway, so that they would be able to send a summary of care for a referral over the HIway. And the other reason is also so that it would allow for a variety of workflows for obtaining consent beyond the front desk staff. With it being in the EHR, medical assistants, nurses, and other staff that don't use our registration system could be responsible for obtaining consent. So we knew that with putting this new burden on our front desk staff, who are already very stressed about a new registration system going live, we had to make this as easy as possible for them and try to give them a package of information that would explain everything as concisely and easily as possible. So what we did was we created HIway toolkits. We made about 500 copies of these toolkits and distributed them throughout Mass General. We also posted them on our privacy and security website so that practices could do their own printing of these toolkits. And we went around to different practices and we trained on these toolkits. And we trained and teaching them about the contents of what's in here. We taught them about what the HIway is, what it means, how to obtain consent, how to answer patient questions, where to get more information. So this is what our toolkit documents contain. And this is, the first page of it is a table of contents. So I'll just walk you through that real quickly. We have a little business card in there, and it says, it gives a one-sentence that staff can use to introduce patients to the Mass HIway. And we did it on a business card so that staff could put this in a place that was easy to read it. You know, just tape it up on their computer or clip it to their badge card or have it somewhere convenient and handy. Also in our toolkit is the Mass HIway fact sheet for patients. This is right out of the box from the community resources that are available on the HIway's website. We wanted to use this form because we think that that it's terrific. It has all the information that they need, and also we felt that if a lot of other organizations are using the same patient handout, that once a patient sees it at one organization, when they come here to Partners or Mass General and they see it again, they'll know what it's all about. So just trying to give some consistency to the patient education materials. We also created our own MGH ramping up onto the HIway, just a shorter patient handout that kind of pinpoints some of the benefits that we think the HIway provides for patients and providers. In addition, we have a copy of the consent form in the toolkit. Although this is electronically and they can print it out of the registration system, we wanted to have a paper version for them in the toolkit so they could look at it. We have instructions for opting patients in that walk staff through what they need to do, starting with looking in the documents table at the status of the document to see if it's been received yet, down to actually getting the signature on the electronic pad. We also have a screenshot that shows them the document table in the toolkit. We have a Q&A script for staff. I think it's about 3 pages long, and we tried to come up with every question that we thought a patient might ask about this and the way they would ask it, and then come up with a 1 to 2 sentence, clear, concise, plain language response. So I tell everyone that they have to do their homework and read this to really understand this, to be able to help our patients. And then there is a PowerPoint presentation that we did for leadership throughout the organization, our practice managers, our administrative directors, our nursing leadership. And last is data elements in a CCD. So our initial use case for the HIway is in October, we're going to start sending out these transition or summary of care documents out over the HIway after a patient is discharged. And this lists the elements out on what's on that document. So people could see, okay, what is this that's actually going out over the HIway? Because sometimes we got some comments and concerns, or, oh, you're sending my whole record out. No, no, this is what we're sending. Okay. Just to note that everywhere I went, all the practices, I was asked about Spanish. Would we have this available in Spanish? So we did get Spanish translations for the patient handouts, and that's been very helpful. So I have the Spanish one here. You can see these are our instructions for opting in patients. This is the screenshot. Should have gone over these. This is our signature pad. This is a picture of what it looks like. So what practices do is they actually are using laminated copies of the consent form that they give to patient to read, and then the patient signs on the pad. And this is a data model for our enterprise consent process, kind of the systems speaking to each other. So you can see that consent data is coming in from Epic, going to our EMPI. It's also coming from local registration systems into our EMPI. And eventually what the next goal is to try to automate a process for these summaries to, for a discharge to trigger this producing of this clinical document, and then looking to see whether or not there's been consent. And if there has, then to have an automated process to push this out over the HIway. Okay. So I talked about our implementation consent work group. This was our dream team that's been meeting since February, and these are the representatives. These are the areas that were represented on this team. We had health information services. We had a lot of people from information systems, our HIway administrators, access administrators, and our EMPI folks, our LMR, our electronic health record folks. We also had people from patient access and registration. We had people from our partners eCare team. We had some clinician input and assistance, and also our legal team. Our decisions from our implementation work group were endorsed and supported by our senior leadership via an HIE steering committee. So that was our governance. But as we looked further at our governance structure, we realized that going forward now, we don't necessarily need a consent work group, but now we need an operations work group for the HIE. So we are in the process now of transitioning that group into a HIE operations work group that would speak in and make recommendations into our HIE steering committee. And that's all I have, so I'll hand it back to you, Sean.
Great. Thank you, Christina. I appreciate that, and thank you very much for sharing everything with the group. Really absolutely wonderful and amazing work. So let me switch over now to our next presenter. Our next presenter is Dr. John Halamka. He is Chief Information Officer over at Beth Israel Deaconess Medical Center. He's also the chairman of the New England Health Exchange Network, co-chair of the Health IT Standards Committee, a full professor at Harvard Medical School, and a practicing emergency physician.
Wonderful. Well, thanks very much. So just like my colleague from Partners, Beth Israel Deaconess engaged all the various stakeholders in deciding how we would accomplish meaningful consent for both push, data going from place to place, sort of replacing the fax machine workflow we have today, but also pull. The idea that you might present to an emergency department and we will gather information with your consent from the outpatient, inpatient, skilled nursing facility, or other places your information might reside. So as a baseline, let's talk about HIPAA, treatment, payment, and operations, and existent workflow and policy. We believe, and the HIT Council, the governance body of health information exchange for the Commonwealth, that novel consent is not needed for the pushing of data from clinician to clinician as part of treatment, payment, and operations. So today at Beth Israel Deaconess, and has been the case since the HIPAA initial regulations were put forward in the late 90s, we have a general consent which describes the kind of care you'll receive at Beth Israel Deaconess, points to our notice of privacy practices, and does enumerate that we as part of treatment, payment, and operations may do such things as send information back to your primary caregiver like a discharge summary. And you sign that consent, but it does not specifically offer a description of the HIway. It does not specifically include educational materials about this idea of a relationship locator service. It's purely for recapitulation of the fax workflow, the manual workflows for point-to-point data exchange that we've had for 20-some years. Now, the manual workflow for the release of data, such as a plaintiff attorney, a government entity, or say a treating physician who requests a record, well, this of course does require a special form, and has for 20+ years, a signed consent or medical record release form. Now, there are ways to make that electronic. An example for you is Social Security Administration some years ago felt that there would be ways to automate the release of information for patients who apply for SSI, for special disability payments. It used to be that a paper-based process would result in a 6-month lag between your requesting disability evaluation and the records arriving at the Social Security Administration and being evaluated. Social Security Administration decided that, well, how about this? We will have an electronic form. The patients will sign an electronic form, and that electronic form with some metadata in XML will be delivered to a hospital. The hospital will then evaluate that electronic data and send back within seconds a complete electronic health record if the consent is appropriate. So these are the existent processes. In effect, signing a general consent, a medical records release, signed, faxed, or an electronic version of that as the Social Security Administration has made available. So for our 2 phases of the HIway, phase 1 being something we did in 2012, this push idea of pushing discharge summaries or PCP specialist referral, this sort of thing, we simply said we are going to get rid of the fax machines. We're going to do point-to-point exchange using the mass HIway to push XML formatted clinical summaries per meaningful use. And this is following the stage 1 and the stage 2 meaningful use standards. Initially the CCD, or continuity of care document, and then the CCDA, using the direct protocol from place to place. And of course, our consent describes our organized healthcare arrangement, our affiliates, and various third parties. And our HIPAA considerations are that we push for treatment, payment, and operations if the general consent is signed to various recipients who are directly involved in the treatment, payment, and operations. We would not push to a third party. The data would never go to a pharmaceutical firm or to a registry for clinical trials without your consent or anything of that nature. I mean, it's truly simply replacing the fax machine, using the HIway to push payloads from place to place, in effect, leveraging existent workflows we had for consent. But as my colleague and partners described, the idea of someone not in your organized healthcare arrangement, someone in an emergency department across the country, I mean, all kinds of use cases you can imagine for pull, is a totally novel workflow. And there are many stakeholders here. So we have the patients who have their own privacy preferences. We have the providers. We have payers. We have third parties providing value-added services, analytics, or quality measurement, or reporting to the government. So we assembled, like partners, a multidisciplinary work group that included IT, health information management, legal, compliance, and interestingly, patients and families. And we had initially conceived a form that was, how would I describe this, Sean? 3 pages of 4-point type with a place to sign at the bottom. And the patients and families said that is not very patient-centric. It may be legal, but how do we really, as patients, when we're in pain, or it's Sunday at 3 in the morning and we're in an emergency department, how do we understand what it is we're signing or what it is we're consenting to? That doesn't really, I mean, it may be legal, but it doesn't produce a meaningful consent. And so, although we wanted to adhere to HIPAA, the HIPAA Omnibus Rule, and Massachusetts laws like Chapter 305 and 224, almost more importantly than that, we wanted to pass the Boston Globe test. If a patient and family member brought a consent in 4-point type to the Boston Globe, how would the Boston Globe react? So our Patient and Family Engagement Council said what we need you to do is separate out this HIway idea and then surround it by a very visible box, and don't just sign here, you've consented and that's opt-in. Actually offer a meaningful choice. You will be signing here for the Mass HIway if you want it. The educational materials describe its risks and benefits. Do you want it? Yes. Do you not want it? No. Your choice, and regardless of the choice you make, your care at Beth Israel Deaconess will not differ. You have total freedom of choice. Now, as a doctor, of course, I would feel that if doctors have more information about you, like your comprehensive medication list or problem list or latest labs, they can probably deliver safer, higher quality care. But you can imagine patients having very different privacy preferences. And Sean, I'll use a silly example, which is it's not true, but it illustrates the point. Being a CIO is very difficult, very stressful, so I needed a month-long vacation at a psychiatric facility. I needed a few weeks at a detox facility. Oh, did I mention domestic violence, sexually transmitted disease, and HIV? Well, I've just enumerated, 5 things that aren't true, but a patient you can imagine who has any of such visits or conditions might have different privacy preferences as to what data is released. So you can imagine a patient saying, yes, I opt into the HIway's relationship locator service for my treatment at Beth Israel Deaconess, which includes a flu shot, a colonoscopy, and an eye exam. But actually, no, I do not opt in for the sharing of information from McLean Hospital, a psychiatric facility, the Betty Ford Clinic, the Fenway Community Health Center HIV Clinic, etc. So when the patients and families heard that our form would give positive choice separate from the rest of the consent and give them the assurance that care would be delivered regardless of their choice, that seemed to both pass the Patient and Family Engagement Test and the Boston Globe test. And the Patient and Family Engagement Council asked for one more thing, which is if it's Sunday at 3 in the morning and you say, boy, I am in pain, I have a lot of complicated medical problems, I really want this HIway thing because I believe it's going to result in safer, higher quality care. But then you recover and a week later you say, oh boy, I actually would rather not have information about me shared. You can withdraw consent at any time and reverse decisions you have made. And so we came up with a second form separate from this opt-in consent that enables the patient to change their mind at any time. And so just to show you what this form looks like, there we go. So there is the general agreement, but then you can see the text box, which notes, I have received educational materials about the Mass HIway, and I acknowledge I have. I will allow the HIway to hold my demographic information, the relationship locator service. Yes, no, my choice, and then you can see I sign, and then I also describe that I've received notice of privacy practices, etc. So this is now implemented in a number of our registration areas. Like my colleague from Partners, we had concerns about added workflow or added stress. And actually what we found in our 4 pilot areas is, since already at Beth Israel Deaconess they are achieving general consent at each encounter registration, that this did not actually impact their workflow significantly. They do hand out educational materials. There was some training so that if questions are asked by the patients and families about the HIway, that they can answer those questions or at least point the patients to others if they cannot. And we mark in our registration system the answers that you have enumerated on this form, and if you answer affirmatively, share demographics, then we send your demographics to the HIway for a relationship locator entry in the HIway. If you answer no, we send your demographics specifically with a no, and then what happens is the state matches existent records and deletes everything. So it's important for people to know the second you opt out, every bit of history of your having opted in any time in the past is redacted, removed, and deleted. So there is in fact nothing in the database that would ever associate you with an institution for which you had opted out. And you can understand, in this world of Home Depot databases getting hacked or iCloud being accessed inappropriately, retaining data for which you had said, I don't want people to know, is very risky. So the state simply deletes all data about you when an opt-out occurs.